Hello, and welcome to the Dance Physio Podcast, a podcast designed to explore ideas and foster discussion around dancer health and wellness. We're here to challenge the status quo, bridge the gap between dance science and the studio, and help change the landscape of the dance industry for the better. I'm your host, Erika Mayall, a dancer turned physiotherapist who is deeply passionate about leaving the dance world better than I found it. I'm so glad you're here. Let's get started. Hello, everyone, and welcome back to another episode of the Dance Physio Podcast. I am your host, Erika Mayall. Before we get started, just a reminder to like and subscribe and share and comment and do all of the things on the podcast episodes. It really does make a huge difference and really helps other people to discover the podcast if they are searching for similar types of content and information. And I have set a goal for myself this year to increase the number of reviews specifically that we are getting on the podcast. So if you have not already left a review or a rating on whatever podcast platform you are listening on, if you can take 2 seconds right now just to go and give it 5 stars, or even better, leave a review, I would so appreciate it. All right, on to today's topic. Today, I want to discuss low back pain in dancers, and specifically, we're going to focus on extension-based low back pain, and I'm actually going to break that down even further because low back pain is a massive topic. It covers a whole range of different conditions that we encounter, and especially for our dance population, low back pain can be quite common. So today we're going to specifically focus on what we often term extension-based low back pain. Low back pain in general oftentimes gets broken down into sort of different potentially causes, or people try to categorize it because it is such a large topic. And that is why I'm focusing on the extension-based aspect of it today. And I'll just explain what I mean by that in a second. Just back pain in general, before we get into kind of the extension-based part of it, is, like I said, quite common, and it's especially common in adolescent athletes, and there are many different causes of it. And like I said, some of it we will then break down into different categories or categorizations. A lot of the times, low back pain, and not just in athlete populations, but in the general population, will sort of describe, if we can't figure out an exact cause of it, it gets described sometimes as non-specific low back pain. So you'll hear all sorts of different terminology, but today what I really actually want to focus on is something that is called spondylolysis. And this is one of the extension-based mechanisms of low back pain that we see really commonly in dancers, and especially in adolescent dancers. We see it in all dancers, but definitely very common in adolescent dancers. There are other types of extension-based low back pain as well. The other most common one that we see is facet joint issues. And so facet joints are one of the joints in the spine, and we can have irritation of those joints, or we can sprain those joints. And I will do a separate podcast episode specifically on facet joint irritation. So that is why today I'm going to focus mostly on spondylolysis. The other terminology that you will sometimes hear is what is called spondylolysis. And that is essentially a progression of spondylolysis. So I'm kind of covering both in today's episode, but I'm not going to get tons into the spondylolisthesis in terms of grading and, surgical management and those types of things, because we actually don't see that nearly as commonly, or at least in an adolescent dance population, we don't see it as commonly as we see spondylolysis. All of these words, kind of long, sound kind of similar, and I just want to make sure that we are also not confusing what we're talking about today with spondylosis. Spondylosis, some of you may have heard that term before. That is often thought of as age-related, but it is more of a degenerative low back condition that's sort of attributed to wear and tear. It's much more of a degenerative issue, and much more commonly seen in older adults. That is not what we're talking about today. Today, I'm specifically talking about spondylolysis or spondylolisthesis. So we're going to kind of clump those together a little bit. So spondylolysis is the most common identifiable cause of low back pain. Like I said before, there's all these kind of like unidentifiable, I don't know if I like that word, but these kind of non-specific low back pain, or sometimes we'll just term things like mechanical low back pain, or all of these very vague classifications of low back pain. But in terms of actually being able to identify a root cause of low back pain, spondylolysis is the most common one that we see. It occurs relatively commonly in adolescent athletes, rates of between 7 and 20% when they look at just general adolescent athletes. So this is across a variety of sports. And it is often asymptomatic. And so we can have people who we might find like an incidental finding of it on imaging. They might be getting an x-ray or imaging done for another reason. And it is incidentally found that people have this. So it's common, but it's not always symptomatic. When we have adolescent athletes who are symptomatic, so they're reporting low back pain, the rates increase quite significantly. There we see rates of between 14 and 30% with this diagnosis of spondylolysis. So when we have pain present, the chances of it being this diagnosis increase pretty significantly versus we see these rates of it in adolescent athletes who they may be totally asymptomatic. It is super common in dancers, and you'll see why in a second. And so when we look at rates of this in dancers, we don't have a ton of information, or I couldn't find concrete numbers on adolescent dancers. But when we look at professional ballet dancers, one study found rates of 32%, which is pretty consistent with that 14 to 30% in those adolescent athletes. And another study looked at comparing male versus female in professional dancers, and there's a higher rate of it in male dancers. So it's 40% in male dancers and 26% in female dancers. So again, a lot of those numbers tend to hover around that 20 to 30% range in terms of dancers who are experiencing low back pain. Potentially between a quarter and a third of them could be related to a spondylolysis. So what is that? It is essentially an overuse stress injury to a particular part of the spine. So it's called the pars interarticularis. You do not necessarily need to know that, but if you do want to Google it, it's called the pars interarticularis if you want to look at what that looks like. But essentially, it is the bone that connects the upper and the lower facet joints on the back of the vertebrae. So I don't know how familiar you are with the anatomy of the vertebrae, and if you don't really know what a vertebrae looks like, definitely Google that just so you can kind of see. But it consists of like a big round chunky bit in the front, and then there's a little hole, it's called a lumen, and that's what your spinal cord goes through. And then the back of it has like the pokey outy part is often how we describe it, but it's the spinous process. And then there are these transverse processes on the side, so these little sticky outy bits on the side. And we call that back part of it the posterior arch of the vertebrae. So the spinous process, transverse processes. And that is where we find the facet joints and this pars interarticularis. It is the weakest part of the vertebral arch, and so it is no surprise that it is then going to be susceptible to overuse stress type injuries. It can happen. So on a vertebrae, we have one of those little pars interarticularis, or like the lamina. They get called all sorts of different things, but there's one on each side. And we can have these injuries that happen unilaterally, so it's only happening on one side of the vertebrae, or we can have them happening bilaterally, so it's happening on both sides of the vertebrae. So depending on the presentation of the dancer or just like what we find on imaging and things like that, it could be just isolated to one particular area, or it could be happening across both sides of, so happening bilaterally in through there. It occurs most commonly at L5, which is right at the very bottom of your lumbar spine. So we number our vertebrae, and in our lumbar spine we have 5, so L1, 2, 3, 4, 5, 5 being at the bottom, 1 being higher up. So most commonly right at the very bottom, L5, and second most common area we see it in is L4. So it's almost always fairly low down in the low back when we are seeing these stress reactions happening at the vertebral level. So What causes it and what makes dancers more susceptible to it? Well, it is caused by repetitive and excessive lumbar extension. So people going into lumbar extension repetitively over and over again. Dancers, check, we do that a lot. And then also excessive amounts of lumbar extension. So again, dancers use a lot of range of motion. So we're doing those two things, going into huge amounts of motion and then doing it repetitively all of the time. So think things like back bends, arabesques, walkovers, bridges, like any of those types of movements are going to be going into that repetitive extension. It is also super common to see it be worse. I don't know if that's the right word, but more common when we're combining a lot of extension with rotational type movements. So if we think of, like a big grand port de bras or, anything that combines extension with rotation, that puts a lot of stress, particularly through that pars interarticularis area in through there. Like I said, it is an overuse injury, and so it is also a load management issue. We know that dancers are going to use extension, and we know that they are going to use extension repetitively, but not every dancer is going to develop this, and so some of the dancers who are maybe more susceptible or more likely to develop it could potentially be because of load management issues where they're just doing such high loading in those extension positions. And we maybe see that more potentially in dancers who are doing more acro or contortion-based things, because a lot of those do involve a lot of extension. If we think of any sort of like chest stands or like any of those kind of contortion-y things, a lot of times there is an element of lumbar or low back extension. It can also be, when we come back to think about like the causes of this, it can also be linked to technique of how somebody is going into that extension. And so what we'll often find when we're assessing or evaluating these people is when they're extending, they might be getting almost all of their extension at one level in the spine, and oftentimes it's low down. It might be that L5 level. They're almost like hinging at that L5 level, as opposed to getting a really nice curve when they go into extension and getting some of their movement from all of those. In an ideal world, if somebody is going into extension, we want each of the vertebrae levels, so L1, L2, L3, L4, L5, we want each of those contributing to that overall extension movement. But what we sometimes see is that people are getting, say 60% of it from one vertebral level, and then the rest of them are not participating quite as much. And that's going to put huge amounts more stress at that particular vertebral level and potentially cause this stress reaction. So that can be sort of, sometimes we'll like term that as like poor technique, but sometimes it's also just the biomechanics of how somebody is moving. And commonly we will see these biomechanics be altered as a compensation for something that is going on either above or below the issue. Like we always want to look at what's happening higher up the chain, what's happening lower down the chain. And so commonly we'll see it as a compensation for what's happening in the thoracic spine or what is happening in the hip. And I'm going to talk a bit more about those when we get into like kind of, treatment. What do we do about this? How do we prevent this? We'll talk about those a little bit more. I'm just going to touch super briefly on the spondylolisthesis, because this spondylolysis, like I said, is a stress reaction that is starting to happen. So we see stress happening at that bone level. If we ignore these issues and we continue to do repetitive extension-based things, that stress reaction can actually turn into a full fracture. So it will then progress to a stress fracture, but then it can actually turn into a full fracture at that area. And if we have a fracture that happens at that area, then we would term it this spondylolisthesis, because we'll actually start to see the vertebra kind of translate forwards a little bit, where they're not actually being controlled or maintained in like optimal alignment and optimal positioning. So that is the difference between a spondylolisthesis versus a spondylolysis. Again, words confusing. But essentially it is like a progression of it. So it'll start as a stress reaction, potentially progress into a stress fracture, and then potentially progress into a full frank fracture in through there. We ideally want to stop that from happening. And that is why I think I oftentimes, at least in my practice, I don't see a lot of the full fractures or those full spondylolisthesis. I do see a lot more of the spondylolysis. So we hopefully are catching it early enough that it's not progressed to that, and then working on treatment and like dealing with it at that stage. So how do dancers who have this going on, how do they present? What are they going to report? What does it feel like? Generally with these, it is an atraumatic incident. And what I mean by that is there was no trauma associated with it. It's what we would call an insidious onset. It just gradually starts to get sore. And so a lot of dancers will kind of report that like, oh, it started out with just my back feeling a little bit tight. Then it started to get a bit more achy. And then kind of slowly over time, it starts to kind of progress and get to the point of more and more pain, to the point where they actually want to do something about it. It is much less likely that there's going to be a traumatic, all of a sudden somebody goes to do one extension and they're like, oh, like I felt something happen in my back and, you know, have had pain since then. That is more likely to be another type of extension-based injury, and probably likely a facet joint injury. Like I said, we'll talk about that separately on the podcast at some point. So with these, generally they are atraumatic, this insidious onset. They are worse with activity, and especially extension-based activities. Dancers will often report like, oh, my back's really, really sore after acro class, or we were working on arabesque last night and doing a ton of arabesque and holding our legs and working on our height, and then my back gets really sore after doing things like that. So it's kind of, with a lot of repetitive extension movements, that is when it's going to be more sore. Generally, it feels better with rest. So if we're not doing anything, we're not moving around, it is generally going to feel better. Generally, I just said that a lot of times, but for the most part, people do not have a lot of radiating symptoms with this particular injury. And what I mean by that, or what we kind of mean when we talk about radiation of symptoms, is pain that kind of spreads above the point of injury or below the point of injury. And with back injuries, especially if there's anything that's related to like the nerve or the disc or any type of those structures in the low back, we often will see a lot of radiation of symptoms, and people will say, I get pain that goes down into my glute, or it goes down the back of my leg, or those types of things. And with a spondylolysis, we generally do not see a lot of radiation of symptoms. It's usually pretty specific, pretty local to the lumbar spine. People will kind of point like right to the center, right to like the bottom of their spine. And maybe they'll describe a bit of kind of like aching or those types of sensations across the low back, but it generally does not radiate up or down very much. We will sometimes see, and this, like when you look at the research, they'll talk about this a lot, but I actually think that this is a poor diagnostic indicator. And I actually don't know that any research has been done to correlate this. I think people just assume that this is the presentation we're going to see. But when you look at the research, they will say that these people will often present with an increased lumbar lordosis and kind of that like anterior pelvic tilt and or tight hamstrings in through there. Again, I don't actually know that that is the case. And especially with the dancers that I have treated and worked with this issue, I would not say that that is the case across the board. I think that that is us assuming that maybe if somebody has a little bit more lumbar lordosis, that they're putting more stress in through that area. But depending on whether it is, you know, just their usual structure and how they're built, it may or may not predispose them to this. So if you're ever reading any of the literature or research, you will come across that. I'm not sure that I totally clinically agree with that. It is certainly something that we want to look at and address in terms of like when we're going to talk about treatment, like what is it that we're working on and what are we trying to achieve with treatment? Yes, we want to address that. But in terms of like presentation or diagnosis, I don't think that that is a diagnostic indicator at all. Much more so that repetitive extension, worse with extension activity, better with rest, and kind of that atraumatic insidious onset, that is what we are more commonly going to be aware of in terms of diagnosing these types of issues. In terms of other diagnosis, we do rely on imaging a lot of the time. So there's going to be our clinical exam, like I just talked about. We're going to do extension-based tests and things like that. rule out other low back pathology. But as far as imaging goes, it can be very, very helpful in actually, sort of solidifying this diagnosis. Like I said, this is one of the most identifiable causes of low back pain versus a lot of other types of low back pain that might be more mechanical in nature or might be a little bit less specific, and we might not pick them up on imaging. In general, we are going to start with x-rays, and we want 2-view x-rays for these. And that is kind of like the standard to start with, and we'll pick up some of these presentations. It does not always pick them up because, again, like I said, it is a stress reaction when it first starts. So we think stress fracture. And if you're not familiar with stress fractures, there is a podcast episode specifically on that. And I talk a little bit more about why imaging may or may not work with stress fractures. So I will link that episode in the show notes. So go check that one out. But essentially, if it's early enough in the diagnosis and somebody is just at a stress reaction type of phase, it may not show on an x-ray. So then we are going to look at MRI generally for acute phase, like early on. If it's somebody who this is kind of a fairly recent presentation, MRI is considered the sort of like gold standard in terms of imaging. But if somebody has had this going on for a longer period of time, it's kind of more persistent low back pain, maybe it's one of those dancers who has been dealing with it and kind of ignoring it and maybe just trying to manage and keep going. So it's been a longer term, more persistent thing. Then CT scans are often actually the more preferred imaging. So MRI or CT, there's pros and cons to both of them. So neither one is going to be the incorrect option. You can use CT scan more acutely. You can use MRI more persistently. But just in terms of like what the recommendations are right now, x-rays first. If that is like inconclusive or not showing anything, then MRI and or CT scan is going to be the diagnostic tools used to determine, again, these more early stage stress reactions. It is not a diagnosis that we commonly use bone scan for, and I don't know exactly why that is. Certainly, again, because it's a stress reaction, or if we're trying to pick up a stress fracture, I think it would show up on a bone scan potentially. But I think because, especially in the case of low back pain having so many different causes, CT or MRI is going to give us a much clearer image if it's not a bony cause and there is sort of a soft tissue issue going on. It's going to give us more information about that. So I think that's why they go straight to MRI and CT and don't necessarily bother with a bone scan for this type of presentation. All right. In terms of treatment, what do we do about this injury? Generally, people respond really well to conservative treatment, and that is going to always be preferred. And what we mean by that is things like physical therapy, rehabilitation. Very rarely is this a surgical issue. Again, if we have people who have those like frank fractures, so it's progressed to the spondylolisthesis, and there's a significant degree of like forward slippage of the vertebrae, so it's like translating forwards, and then they're getting a bit of neurological compromise with like nerve symptoms or that type of thing, that those cases they may actually look at surgically stabilizing, but the vast majority of these cases are going to be managed conservatively. The biggest thing that we need to look at is load management, or what we sometimes call relative rest. And this is especially relevant for avoiding extension. And this relative rest, or this like load management, actually looks quite different depending on the severity of presentation of symptoms, and also how concerned we are about it being like a stress fracture that we're worried is going to progress to a frank fracture versus a more mild stress reaction type presentation. So in the more mild stress reaction presentations, our load management might actually just be that we're going to avoid extension, but a dancer may still be able to participate in a lot of other aspects of class and of training if we're keeping those that extension away. In more severe cases, sometimes this load management actually looks like complete rest for up to 3 months. I've had very few dancers who've had to go that route of like that conservative of treatment, but it certainly does happen, and which is also one of the reasons why we want to address this extension-based low back pain earlier rather than letting it continue on. Because the earlier we can catch it, the less limited our dancers have to be in terms of managing the condition. So like I said, if we're catching it early and we're just trying to like limit, progression of it and kind of calm it down, oftentimes it really is just limiting or avoiding extension, and they can actually still continue to participate in other aspects of dance classes. We want to look at early initiation of physiotherapy. There's been research that has looked into this again previously, or sort of like a little bit of an older approach to managing these was kind of an across-the-board recommendation of 3 months of rest, and then physical therapy was often not initiated until the end of that 3 months. So these people were like kind of sitting around doing nothing for 3 months, and then when they had done their nothing for 3 months, then they were starting rehab and physiotherapy. We now know, and there's been some studies that have looked at it, that people who actually initiate physio early, whether they're taking a full 3 months of rest or whether they're just like modifying loading within class, if they're starting physical therapy or rehab early, they actually have earlier return to dance and to sport outcomes. And so we do want to initiate it as early as possible. I'm going to talk a little bit more about what that rehab looks like in a second. Before we get into that, I want to talk about bracing a little bit as well, because again, previously bracing was really commonly recommended. So it was like 3 months of rest with a lumbar support brace that was going to like kind of keep the spine fairly like neutral or rigid and not allow any sort of extensive like extension movements. But there's been some meta-analysis done that is actually found that bracing is not effective had not had an effect on clinical outcomes. And so now bracing is not necessarily the across-the-board recommendation. There may be certain cases and certain populations where bracing may still be indicated. But in general, just as like a blanket across the board, bracing is no longer considered like kind of the first thing that we do. So we're having much less periods of unloading. So a lot more of that relative rest as opposed to complete rest. And we're not necessarily going straight to bracing. And it's really more about early initiation of physio and kind of like rehab. So what does physio and rehab look like for these? A lot of it is looking at trying to stabilize the spine and retrain patterns of extension so that we're not getting those kind of compressive, irritating forces in extension. There's been some protocols that have been developed and kind of proposed that break down the rehab into 3 phases. And I think that this makes good sense in terms of how we're going to look at it. And I'll actually link that in the show notes as well. So if you're interested in actually looking at that kind of like rehab protocol, I'm just going to like really briefly touch on it, but it's a bit more extensive than that. So I will link that in the show notes as well. But basically, they are looking at in phase 1, we're essentially looking at trying to stabilize and work on core control. And so that can be our deeper core muscles. That might be more global stabilizers, but in very static or neutral positions of the spine. So this might look like core exercises where we're lying on the floor of the bed or whatever, and maybe we're doing leg movements or arm movements or things that are challenging the core musculature, but the spine itself is staying really neutral. This could also be exercises that are being done in, I call it like a bear plank position, but if you're on hands and your knees, or some people call it a hover plank, or it gets called all sorts of different things, but where you're in kind of that position, again, spine is staying totally neutral, totally still, and then we're challenging the loading around it. So phase 1, really looking at kind of like static and neutral spine loading in terms of controlling those movements. In phase 2, it is looking at integrating training into these, they call them like sport specific, but in our case it would be like dance specific movements. So it's all fine and good for us to have like good core strength and be able to really control our core or control our spine in that straight position. But as anybody who has ever danced or worked with any dancers knows, dance involves huge amounts of spinal movement. So the second phase of rehab needs to then be working on more stability and control through dynamic movements. And so this could look like things, and again, if we think of Pilates influence or stuff like that, but doing, say, like a glute bridge where we're actually like rolling segmentally through the spine. So having to control those movements more segmentally. But it also needs to look like including extension and rotation-based movements. And this is one area that I would say I often see kind of neglected in rehab. And even I think the authors of this paper where they were looking at developing a protocol, they commented that it was something that was often neglected as well. Like the focus was so much on, okay, stabilize the spine, work on it in neutral, brace it, don't do activity, all of that. And then it was kind of like, okay, go back to your sport, but your sport involves extension. And they hadn't retrained those kind of extension or worked on strengthening in those extension or extension and rotation type movements. So phase 2 of rehab is going to be looking at controlling and building strength in those movements. And then phase 3 would be the like return to dance. So how do we then integrate that in a gradual return to dance in terms of gradually increasing the loading back with extension or extension and rotation movements? We are always going to look at the areas above and below, like I talked about. And so specifically for these areas, I would say I'm always looking at thoracic mobility and not just extension. I think a lot of people are like, okay, yeah, we're going to look at thoracic extension and make sure they can extend through there so that the lumbar spine isn't working too hard. But definitely looking at thoracic rotation as well, because that is often an area that a lot of dancers are lacking in. And so then there's more stress being put in other parts of the body. So really working on thoracic mobility and potentially strength, depending on how the dancer is presenting. And then, like I said earlier as well, hip. And this is oftentimes hip extension specifically. And sometimes it's the mobility of hip extension, but more often than not, it has more to do with the patterning or the technique that a dancer is using to extend their hip behind them. Because what we see a lot in dance populations is dancers really use their lumbar spine, their lumbar musculature to help try and get their leg higher behind them in an extension, and they're not necessarily using their glute as efficiently or effectively as they could be. Our hamstring is also a hip extensor as well. Most dancers are actually good at using their hamstring to extend their hip. They're not as good at using their glute. So we want to look at the patterning of those muscles and potentially looking at building up some of those where we can work on true hip extension that isn't involving lumbar extension to really build up that musculature, and then combining the two. Because if we think of a move like an arabesque or an attitude or like anything where your leg's extending behind you, it is a combination of hip extension and lumbar extension. But if we're lacking in the actual hip extension part of it, then all of that force is going through the lumbar spine, and that's what we don't want to be happening in these cases. So certainly spending lots of time looking at above and below the area, thoracic and kind of hip and pelvis area as well. And then we do want to look at correcting any kind of like technique or biomechanics issues that we're seeing. So this may be when we start to look at what is this dancer's natural tendency in terms of their pelvic placement. So do they like to stand in an anterior pelvic tilt, or when they are extending, are they hinging from that one particular area, or are we getting smooth kind of control of that movement? So we are going to look at that biomechanic and technique element of things as well before I'm looking at this like probably right from phase 1, although we might not be able to do tons with it in phase 1 if we're still really just working in a neutral spine position. But certainly from phase 2 of rehab, we're going to be looking at this. So by the time they get to phase 3, which is like that integration of a return to dance protocol, we have addressed some of these biomechanical and technique issues and are getting, really good, smooth extension that is not necessarily overstressing one level of the spine. So that is, in a nutshell, what we're looking at in terms of like rehabilitation or treatment for these extension-based back injuries. The thing I want to like reiterate or kind of emphasize the most is that we do need to actually work on extension in these clients. So often I see people who, if they've been to another physio, or even if they've just kind of like taken time off dance themselves, they've let the pain calmed down, they are sort of trying to self-manage it, and then they don't actually work on retraining those extension movements. So when they return to dance, the problem kind of creeps up again because, again, you're going back into that repetitive extension, repetitive loading in through there. So we really want to make sure that that is a part of the rehab, and it is something that we are addressing in all of the dancers who are presenting with this extension-based low back pain. All right, that's all I have to say about it today. Like I said, it is a big enough topic in and of itself that I wanted to focus specifically on that today. I will do another episode on facet joint irritation, which again is also an extension-based low back pain issue, but slightly different in terms of presentation or potentially how we're treating it and those types of things. So stay tuned for that. It will be coming up in the next little while. If you have any questions, please feel free to reach out to me. I am more than happy to answer questions from any listeners of the podcast. And thank you so much for being here today. I really appreciate your support, and I hope you have a great rest of your day.